Welcome to Bridging Researchers and Impacted Communities for Health Equity in Breast Cancer. This is the first in a series on advancing health equity in breast cancer. My name is Merlene Tucker, and I'm here with my colleague Jeff Bornstein. Together, we'll be running this Dialogue for Health web forum. Thank you to our partners for today's event, UCSF Comprehensive Cancer Center, the Latino Cancer Institute, Tiger Lily Foundation, and the Women's Cancer Resource Center. Now it's my pleasure to introduce Catherine Thomsen, the moderator of this event. Catherine joined Zero Breast Cancer in 2014 to promote health and wellness and prevent cancer. She received her master's in public health from Portland State Oregon Health and Sciences Universities, and her BA in International Relations from Pomona College. She's currently Zero Breast Cancer's Program Director. Welcome, Catherine.
All right, good afternoon. Thank you so much for joining us. In honor of the 25th anniversary, Zero Breast Cancer is excited to present this first in our series of webinars on advancing health equity in breast cancer. Great. Okay, so most of you probably realize that cancer is often a greater burden on communities of color, people of low income, those of us with disabilities. And by engaging people who are impacted by cancer, we think that research can be more relevant, and we can also more quickly to improve health equity. So first off, what is health equity? A favorite definition is that when everyone has the opportunity to attain full health potential and no one is disadvantaged from achieving this potential because of social position or any other socially defined circumstance. So health is not just an absence of disease. Our health is definitely impacted directly by our mental and emotional state, as well as our social, economic, and our spiritual well-being. When we talk about advancing health equity, we mean addressing the systemic disparities that exist between more and less advantaged groups of people. An important way for us to improve health equity is to involve diverse communities in research. And there are three main ways that people and community organizations can have an impact in research and in advocacy. And those are to help set relevant goals and make sure that the research questions and the interventions that are undertaken are useful to those who are most affected. Then also the process, if people from the community are involved, they can make sure that the data are collected in a respectful way and build trust. And then finally is dissemination, making sure that the science is not only gathered in a way that other scientists and gotten out to the world in a way that other scientists can understand, but also so that the more general population can understand it. And to also to make sure that the materials are engaging. So at CBC, we connect communities and researchers, creating a bridge in all of these areas. And today we want to discuss how people can provide their critical perspectives and bring their voices to help shape research and benefit our communities more quickly and more directly. We're going to have about 15 minutes after our speakers for a conversation about how to involve more people of color, different social status, gender identities, abilities, and non-English speakers in research and in advocacy. So as Merlene said, please do write your questions and ideas in the Q&A feature. We will also be sharing some links as we go along in the chat, so look for those, even though you can't use the feature to write yourself. Before I introduce the speakers, I want to tell you a little bit about Zero Breast Cancer, or ZBC, and how we have been building a bridge between community and scientists to improve cancer research, as well as our own research and education for about 25 years now. In 1996, a group of otherwise healthy women wanted to figure out what caused their breast cancer, why the local cancer rates were so high, and how to protect their daughters, their nieces, and future generations. So they started this organization now known as ZBC. In 1998, they began collaborating with the University of California at San Francisco, UCSF, researchers to see what behaviors and aspects of the social and physical environments during adolescence, a time when the breasts are developing, might affect our risk. So we have built on this with our chronic disease prevention approach to health education and outreach. And the first effort at that time was working with high school students and their parents to create a curriculum in English and in Spanish. And here you can see pictured at the bottom just 3 of the dozens of teens that were involved in that. Around the turn of this century, the ZBC founders were part of a group of activists who pressured the government to focus research into the causes of breast cancer, not just a cure. In 2003, ZBC joined a national multidisciplinary group on a National Institutes for Health funded breast cancer and the environment research program. So collaborating again with UCSF, ZBC helped lead work on outreach, translation, and communications to the broader public. We also worked with Kaiser Permanente Northern California on one of 3 US studies following hundreds of girls who started the study between 6 and 8 years old and followed them through puberty. Now, while the girls were still young, we actually produced a video about how breasts develop and how cancer can start, called the Breast Biologues. And this was done with input from teens. And there will be a link for that in the chat. So collaborating, as the girls got older, we needed to hear directly from them about what worked for them about the study, how to improve data collection, and how to keep the study members, as well as how to promote health to other adolescents. So we recruited a group of girls between 12 and 15 years old and formed the Youth Advisory Board, or the YAB. They worked together with us to create a brochure to help the participants know what they could expect from being in the study. And they improved tools for tracking their periods, made presentations to younger kids, created a photo voice, and other projects. So it was great to work with these girls and with a really diverse group of scientists. This work led to a book by the experts, The New Puberty, and then we worked with the teens and others to create a campaign called Girls New Puberty. There are links to some of the different materials that we have developed, infographics, videos, and an e-guide. And those are in English, Spanish, and in Chinese. So please check them out. This has become the model that ZBC uses to facilitate relationships between communities and researchers. And for more than a decade, we have worked with Kaiser Pathways on the Kaiser Pathways Breast Cancer Survivorship Study. For the last 5 years now, we have had a community advisory board. In 2016, we recruited the very diverse group, and I have the honor of facilitating this amazing group of women who have shared their experiences to help to shape the research. They have added topics to the study, questions for the annual survey. They've tested and improved the questionnaires for not only the pathways, but also some related studies. And they are setting priorities and contributing on articles that we have written for the Pathways newsletter, which are now being adapted into survivorship fact sheets that we can then disseminate to breast cancer survivors more widely. We are also working with the Child Health and Development Studies. This is a 50-plus-year-old project involved, and we are involving 3 generations in the development of a new campaign. The goal here is to reduce exposure to harmful chemicals among young people for their own health as well as the health of future generations. My colleague Leanna Hartmore is facilitating this group of advisors, and they have helped to design educational materials like the one you can see here, as well as guiding priorities for this campaign. including making sure that men are a target audience for the education. So we are always open to new partnerships with scientists and communities, and also to help others engage communities. We welcome feedback on our materials from as many people as possible on how to improve the videos, our infographics, and the written materials, all of which, again, are freely available on our website. So please contact us, sign up for our newsletter, donate online, and of course, you can follow us on social media. Now, it is my pleasure to introduce three inspiring women. I'm not going to read their full bios, those are available on the website, but I'm going to go ahead and introduce all three, and then they will speak in sequence. So Dr. Kim Rhodes, our featured speaker today, is the Director of the Office of Community Engagement and Associate Director of the Office of Community Outreach and Engagement at the Helen Diller Family Comprehensive Cancer Center at UCSF. She is also an associate professor in epidemiology and biostatistics at the UCSF School of Medicine. Isabel Duron has founded two organizations to help Latinos and Latinx with cancer, including the current Latino Cancer Institute that she'll speak about. She is one of the nation's leading authorities in Latinx Hispanic cancer education and advocacy. And finally, Dr. Jasmine Wong is a breast cancer surgeon at the Carol Frank Buck Breast Care Center at UCSF and at San Francisco General Hospital, which is a safety net hospital. Dr. Wong is an excellent example of how clinicians help involve patients and others in research, improving diversity and representation to make sure that we can better address health equity issues. So now, Kim, if you would please take it away.
Okay, so Catherine, thank you so much for inviting me to share my strong opinions about the need for humility in our academic institutions in order to engage diverse communities in cancer research. I first just want to sort of credential myself because my diverse background and training really influences my opinions that I'm going to share with you today. So I have broad training in, of course, clinical medicine, in colorectal surgery, and then in research in cancer outcomes in California. But I've also had extensive training and background in working in community-based organizations, and training as a community organizer, and then having additional training in community-based participatory research. These experiences influence my opinions and views on the way healthcare interacts with communities. But even more than that, I'm influenced by the experience of my favorite aunt who was diagnosed with breast cancer at the age of 58. And her experience sort of interfacing with the healthcare system or not wanting to interface with the healthcare system informs a lot of my beliefs. She developed a locally invasive tumor that had actually grown so large that it eroded through the skin. She was admitted to a safety net hospital in Norfolk, Virginia, and the tumor itself had become super infected. So because it broke through the skin, developed an infection. She was given antibiotics and then offered chemotherapy. And she was never offered palliative radiation therapy, which I have necessarily saved her life, but probably would have altered her clinical course. I made a phone call as a second-year medical student to try to help my family understand what was going on, but was abruptly dismissed when it was felt that I might be a nurse. When I informed them that I was a medical student, they hung up on me. So what that really showed me was the change and ability of healthcare systems to really respond.
Oh yeah, I think we lost Kim. Let's go ahead and just move on, and then we'll bring Kim back on when she's reconnected to us.
Okay, great. So Isabel, then you are up. If Jeff, if you would please start the slides for her.
Thank you. I'm so sorry we lost Kim, because the work that she's done and is doing through the Office of Community Engagement is so crucial, and particularly even a setup for the work that I do, since I sit on her cab. But thank you, Catherine, for bringing me aboard, and hello to all of you out there who are participating and care very much about this topic. I've asked Jeff to help me, so he'll move along my slides. So next, Jeff. I wanted to give you a bit of the backstory, because I think it's the idea of being an advocate is not often about your decision making, but how it finds you. And so I was already a long-term journalist. I was a TV newscaster in the Bay Area. I was suddenly in my 50s diagnosed with cancer. As a trained journalist, you know, I like the facts, they're my friends, but advocates come with another sort of requirement. In many ways, a journalist to some extent is about advocacy, gathering the facts, turning the spotlight on a need, finding out who has a solution, which journalists then share with the public as a teachable moment. But we just start short of implementation, and the challenges on that end, of course, are the problem. That's where the advocacy comes in. Usually it's about not enough people power, not enough money, or the power of people behind you. But that is where we start to do our work. I came to advocacy by way of my own cancer diagnosis, as I mentioned, in 1999. I had Hodgkin's lymphoma. I very clearly remember thinking two things when the doctor told me I had cancer. The first was, okay, God, this isn't about dying. What's the point? And the second was, I wonder if I should do a story. So I did. I turned the camera on myself and other cancer patients as we journeyed through this very challenging, sometimes horrifically painful experience, as many of you survivors out there might know. But what that three-part series did was to cast me in the limelight, and a request from another cancer advocate who asked me to meet with a group of Latinas who are providing support services for Spanish-speaking breast cancer patients. I told them in my meeting their work was crucial, that they would certainly, the need would grow, and that they would probably need money to help them grow, and so they should become a nonprofit. The short story is that they considered the idea for a number of weeks, and then one of those meetings, I walked out of the room and they elected me president. So such began my pathway to advocacy. And here one has to listen to one's voice. And I eventually said, okay, God, this is the point. So next slide, Jeff. So it's now been 21 years since I started on that pathway, though I stayed in journalism until about 6 years ago. It's been a roller coaster ride, a learning curve the whole time. And while I hope I've been of some help, I also know it's been a great challenge, it's been a burden, and it's been a joy to embrace the work that I have done. I'm going to share it more with you on a macro term. Catherine said I had started two agencies. Actually, I'm on my third, but all of it has been such a great way for me to learn from the community itself, their challenges, and there is where I teach from the ground up. And so as my team worked to address gaps in services along the cancer continuum, from education to screening, diagnosis, treatment, and end of life, this is how I began to understand where systems were failing, in particular the low income, low literacy, Spanish speaking community, who had less access to quality care, as Kim started to describe for her relative. And and looking at these things, I knew this was the place where I needed to do my work. So as you can see by these 5 aims, these were the things where I said very broadly and at a macro level that I have to work. So in the broad scheme of things, we developed educational tools geared to a low literacy Spanish speaking community, addressing both cultural and social norms. We increased access to care by bridging those educational events into screenings and partnered with clinics at all times, working toward that quality experience for the patient whose barriers to care are broad and deep. And on the third point, in increasing access and improving the quality of care, we also ventured into a long-term contract of over 10 years with the Santa Clara County Sobrato Cancer Center by introducing and piloting their first community health worker as a patient navigator. That navigator provided Spanish-speaking cancer patients with a potpourri of services over time, morning, noon, and night, She was a 24/7 person and went to at least 25 funerals during her time. She supported up to 1,000 patients in their decade of service. And I remember like it was yesterday, the difference she made for those patients. She asked, I asked one of the colorectal patients who was dying, how is it that Claudia, out of all the things she has done, made a difference in your life? And she said, she speaks my language. And this is why when I advocate, I am so fervent about the need to address the language barriers, because that is the conversation we all have from the heart. It's not the head that's talking, and that language is about the heart. And therefore we need to make sure that that we're providing, medical, very complex medical information in a manner and a language they hear. So between the patient navigator and the language, those two provide a difference in the quality of the care. So that goes to my fourth point, because I felt that we started to address structural barriers and problems that existed. So we were hoping and trying to point towards the increasing of the Latino workforce. This was a pilot, but a great model if systems are willing to invest and consider deviations from their own norm. And finally, through my 3 agencies over the past 15 years, I spent an increasing amount of time and effort building collaboration with cancer researchers, which has really been, as a journalist, an excellent thing for me to be, but also to learn from, but also to be able to engage the community. Science meets service. These are where the community needs to understand it, not fear it, be a part of it, and provide some of the solutions that we're all looking for. Next slide, please. I want to make sure I'm keeping to time, so yell at me if I'm over, Catherine. Time, Isabel. Okay, so let me show you this. These are the places that I now use my voice at national and federal level. Next slide, please. And I'll end up here, Kat. So these are, if you choose advocacy, you choose to make a difference. You need to get involved. You decide where that is. Identify your passion. That will drive you on that pathway. And please find the joy of it, because it really does make you feel good when you know you're making a difference in other people's lives. Thank you.
Thank you, Isabel. Kim, now that you're back with us, are you ready to start up again? You're on mute, Kim.
My entire house lost internet, so I'm on a hotspot now. That was my backup plan. And I just caught the end of Isabel's talk, and I really, I think maybe we should have been reversed in the first place, because she does sort of set the tone for the broader message of what I'm going to get to here. So let me share a screen. Okay, when I fell off, I was describing the disparities in California in cancer survival by race ethnicity, and just making the point that while some disparities have sort of narrowed when you look at lung cancer and the difference between white patients in the red line here and African-American patients in the blue line, it looks like these lines are going to come together. But when we look at breast cancer, what we see is that actually the gaps are potentially widening. And these trends are related, I believe, to actually differences in the quality of care. However, our traditional explanations often are only focused on the individual. So we sort of see the patient as the problem. We point to chronic comorbidities, and we talk about late stage of disease at the time of presentation. Sometimes there's a generosity in saying, well, the person didn't have insurance, and so that's kind of explains why the disparities are occurring. But we fail to recognize that insurance in this country is tied to employment. So in some ways, we're also blaming the patient again. And now, as we move into looking for genetic explanations for disparities, what we're starting to do is wash our hands of something that effectively we can't change because you were born with it, and therefore there's nothing we can do. But the reality is that health disparities occur at the population level. They're not occurring at the individual level. So why I want to just kind of give an example of population level problems. So why would my outcomes as a woman who lives in California look like the outcomes of an African-American woman who lives in, say, Arkansas or South Carolina? And I'm trying to hit on states that have not expanded Medicaid or that do not have sort of a social safety net around health. You know, the only thing that we have in common is our race. So let me give you a different example. What about groups such as those living in rural areas with low access to care, or those in the LGBTQ community, who also, both of these groups suffer disparities in cancer outcomes? But they have multiple different racial and ethnic groups involved in those clusters of demography that I just described. So this suggests that actually there's something going on at the system level. It cannot fully be explained at the patient or the individual level. So what I'm showing you here is some work that we did in 2015, where we looked at folks who got care in an integrated health system where all of the care for cancer was provided in the same system. So surgery, radiation, chemotherapy, because we were talking about colorectal cancers. And on the right side, we're looking at folks who were treated in sort of the traditional model, where maybe you got your surgery at one place and then you went to back to your hometown to get chemotherapy or to have radiation ahead of surgery. And so the care is actually fragmented. And what we saw, and what I'm showing you here, each of these individual lines represent the survival curves for different racial and ethnic groups that are listed very far to the right in the legend. And what you can see is that the folks who were treated in an integrated system, where we were very clearly able to show that there was a consistent delivery of the same guideline-based recommendations for care, that there were no real differences in survival by race ethnicity. But when you look on the right-sided panel, where people are treated in the traditional model, where care is very fragmented, which means that there's lots of variation in care, you see that there are wide gaps and disparities. So this again suggests that there must be system level drivers that are creating or driving these differences. What this also shows us is that place matters for cancer care, and where you get care determines the care that you're going to get. And that can sometimes have a significant impact on outcome. That also includes whether or not you'll be offered the opportunity to participate in clinical trials, which should be a standard part of clinical care delivery in cancer. So this graphic is quite old, but it has never been really contradicted. And what it shows is that racial and ethnic diversity in participation in cancer clinical trials is quite low. The graph on the left, the pie chart on the left, shows you that the rate of racial diversity in clinical trials in the United States is less than 10%. On the right, we see that ethnicity is even lower in terms of diversity. Now, what most people go to right away is trust. And I just want to propose, before we sort of again blame the patients for not participating because of whatever explanation that typically ends up with this concept of a lack of trust, I want people to consider the possibility that this lack of trust is actually an expected response to historically untrustworthy behavior by institutions. And I probably don't need to say, but I'll invoke Tuskegee and Henrietta Lacks and the Guatemala study with syphilis, which are offenses that were committed by institutions against communities. So this lack of trust, we have to understand, it is there because systems need to change, not because people need to magically become more trusting. But I want to share with you a study by Unger and colleagues at the University of Washington, which was published in 2019. And I really love this study because what they did was they said, we're going to step back from blaming the individual for low levels of participation, low levels of diversity and engagement in clinical research. We're going to ask a question about systems. What are the structural, clinical, and physician level barriers on top of individual concerns that drive participation in trials? So they searched the literature. They looked at about 13 studies, and those studies had very accurate information about the race ethnicity of the participants, as well as information about the location of the trial itself. The study included about 9,000 patients. They used a different framework. They didn't just blame it on the patient. They started at the top and asked the question, is there a trial available for the participant at the time that they were diagnosed in the location where they were being treated? Then they asked whether or not there were clinical reasons to disqualify someone from eligibility for the trial, often something like kidney disease, because your kidneys are essential for metabolizing some of the different kinds of trial medications that you might receive in a cancer clinical trial. And then they looked at whether or not the physician recommended the study or offered the study, and then how patients selected. So this graph shows their results. And I want to just explain first that in the white bars, what we're looking at is trial participation in academic institutions. The gray bar represents community-based practices. But I want you to pay attention to the blue bar, because that's the grand sum total of both settings. And what they found was that in over half of cases, there was no trial available for the participant at the time that they were diagnosed and treatment plan was being devised. About 20% fell off because they were ineligible for the trial. 15% decided not to enroll or were not offered by the provider, which leaves about 8% that did finally enroll. So this points to the fact that population level problems, which we can characterize participation or lack of participation in trials as, actually require system level solutions. I have some questions about the Unger study. For example, in those 55% of people where there was no trial available, why did institution not look for another location or identify another trial for that participant and help them get to that trial? I think it requires some humility on the part of institutions to actually admit that we don't have exactly what you need, and maybe you need to go elsewhere, and we will help you get there. What needs to happen is that institutions need to step back and actually meet people where they are and start thinking about how we can create, for example, patient-centered clinical trials portfolios. I've been agitating and advocating for this in my own institution. Part of the issue is that clinical trials and the clinical trials portfolio and what's available is often driven by the interests of the providers inside the institution. Cancers that are rare or niche are opportunities to make a name for yourself and a career, but often have nothing to do with the patients who are coming into the system and whether or not those trials would be applicable to what they need at the time. So what could happen and what should happen, and what I think that advocates and activists should agitate for, is for institutions to be really intentional about the development of their trial portfolios. Look first at what the patients who are coming to that center need, and then make decisions about who can open a trial, and then be expeditious about getting those trials open. As Isabel referred to, partnerships are critically important, especially with community-based care settings, as well as community-based organizations. But community-based care settings for cancer are where the majority of people are actually getting their cancer care. They're not going to these big academic centers. Also, the centers outside that are treating cancer, outside in the community, tend to have a much more diverse patient population. And so that's actually where patients are. We should try to meet them there. And then finally, to just reinforce the idea that what we need is input from the patients who are using the facility and the communities who surround the facility about how we design our clinical trials, how we tailor the materials, how we approach to offer trials to people, really should be influenced by patient family advisory councils, as well as partnered community-based organizations. So I just want to end by saying that the system really won't change unless we organize first and demand it. So offices like my own, the Office of Community Engagement, where our goal is to sustain community partnerships regardless of whether or not there's a trial to be joined or research to be done, but to just remain in dialogue over time with the community to hear their voices and understand how we can start to infuse that across our research enterprise, as well as the work of this organization, Zero Breast Cancer. This is the way that we're going to move forward and actually shift the agenda toward one that serves health equity. And I just want to congratulate Zero Breast Cancer for 25 years of really pioneering this idea of bridging community and researchers, and starting to integrate and infuse the voices of communities as well as advocates and activists, again, to drive us closer to our ultimate goal of cancer health equity and the elimination of disparities. Thank you.
Good morning or good afternoon, wherever our participants are located. My name is Jasmine Wong. I'm one of the breast surgeons here at UCSF, and I would like to first thank everyone for the opportunity to participate in this very important webinar. And I wanted to spend a few minutes talking about precision breast cancer screening, one of the studies that we have open currently that hopefully will help us move from a position of debating to a position of wisdom. So our current guidelines for breast cancer screening in this country come from a variety of medical groups and societies, which have each chosen and published their own screening recommendations based on a variety of different levels of evidence. And as you can see here, the United States Preventive Service Task Force, the American Cancer Society, the American College of OBGYNs have each published their own guidelines, and they can see that they are sometimes recommending yearly mammograms, every other year mammograms, and there's differences across age groups as well. What the Wisdom Study is looking to do, and the Wisdom Study stands for Women Informed to Screen Depending on Measures of Risk, is looking to compare personalized breast cancer screening to standard screening. What makes this study different than other clinical trials is that the patients have the choice to choose whether or not they want to be randomized to a group, meaning that the computer chooses for them what they want, or they can self-select if they would prefer to have personalized screening versus annual screening. The goal of this is to obviously better understand the different risk factors that each of us individually harbor, and to understand how we can better screen each woman according to their risk. So you may ask, how do you participate? Women are enrolled and participate completely online. There is no requirement to travel to any recruitment center. It can be done on a website using your phone, your computer, or any other available device. All study services are rendered virtually. There are no additional visits that are required to participate in the study. And all of the information that we generate about your risk and what we recommend is sent directly back to the participants and shows up in their little portal. And all of this obviously is personal and confidential. Our study has also strived to be patient-centered and inclusive. We currently have available material both in English and Spanish. Other languages are likely coming online in the future, but for right now, it is a bilingual opportunity for everyone to participate. Once you've enrolled in the study, every woman receives a screening report. The report tells you the age at which the study recommends starting and stopping screening, the frequency of screening, either every year, every other year, or more frequently than that, and what type of screening modality we recommend, traditionally the mammography, the addition of ultrasound or MRI. And it also provides a printout as to what risk reduction strategies we also recommend. Because what we know at the end of the day is that one size does not fit all, and that every individual woman should have their own screening regimen created specifically for them. Thank you so much.
Thank you, Jasmine. I'm so impressed by the Wisdom Study and the fact that you not only are actively working with patients at an academic center, but as one of the things that Kim mentioned in her talk, that most people are receiving their care from a community hospitals and community clinics, not from academic institutions, especially people who have lower income. So the, potential to have more people involved and that are from a more diverse backgrounds is, I would imagine, much better that way. Before I put on a couple more slides, can you talk about how you approach patients? Is there a difference between how you approach patients and talk to them about clinical trial enrollment or getting involved in research in the academic at UCSF versus at San Francisco General?
Yeah, that's a really good question. I think that I try to approach all my patients in the same way, regardless of which hospital I happen to be sitting at. I think the reality is that being treated at UCSF, there tends to be a little bit more access to a variety of clinical trials that are not necessarily open at San Francisco General Hospital. But if there is an available trial that I believe that a patient would be eligible for and would benefit from, I oftentimes will ask to see if I can transfer their care from San Francisco General to UCSF, because the two hospitals are essentially sister hospitals. A lot of the faculty work at both locations. And so sometimes it's a matter of making sure that the patient is comfortable transferring their care from what they consider their healthcare home. And we also make sure they realize that transferring their care does not mean that they can't return to San Francisco General, and that they're just being offered an opportunity locally that may benefit them that is not necessarily available right at that specific hospital.
Right.
Can I just add something
Please.
on to that? Because so part of our role in the Office of Community Engagement is to facilitate partnerships between research teams and the community. So what we have done is built what we're calling the Community Leadership Advisory Board for the Wisdom Study, to help actually tailor materials for specific groups. So we have individual stratified working groups. So there's an African American working group. There is, and it's not just for African American people, it's for agencies who serve African American women. So they also have a touch and a stakeholder sort of skin in the game in how their clients actually get engaged with these studies as well.
And Isabel, you mentioned that you were involved in one of the advisory boards with Kim?
Yes, I sit on the Office of Community Engagement, CAB, which I've been there forever, so long that my hair's gone white. But Kim is doing an excellent job, because it's really evolved over time as to how community organizations are involved. But I think that what's really important is, as for advocates, they need to engage in these kinds of opportunities, because they have to grow that muscle. They sometimes have to push against, and Kim has mentioned it, push against established systems that have a lot of power. But if they know the community and they know their needs, they have to be willing to get in there and defend that position, even using research against those establishments that someone else has developed for them, if they're lucky. But to be able to get every kind of research they can to defend their position, and not be afraid to use that voice, because in some cases, you may be the only one advocating for that particular group in that particular moment. So, but certainly on something like CAB in a major academic center also gives you networks and peers and some power, I think, to, the wind beneath your wings, if you will.
One of the major obstacles that we have at Zero Breast Cancer when we are trying to involve people either from the studies or from the community at large is engaging people who are lower income, don't have the same access to resources like transportation, might be working multiple jobs, childcare, et cetera. And I think that during the pandemic, the Zoom and other technologies have helped to make this a little easier. I'm going to share this slide. Oops. I thought I was sharing the right slide. There we go. And I know that we have questions also coming in. So there are, as you mentioned, Isabel, numerous ways for people to get involved. And I'm curious for the panelists, how you make sure, Kim, that you have a diverse group of people from different backgrounds and with different perspectives and experiences?
So for in our Office of Community Engagement, we're very intentional. We pay close attention to our catchment area, which is 2/3 of California. So it's the 48 counties of Northern California, which only excludes, I think, 11 counties. And so what we do is we lay out a grid, and we have that grid goes across the cancer continuum from screening and early detection to treatment, survivorship, and advocacy. And then down the other side of the grid, we look at the geography. So we look at the different counties, and we fill in that grid to say, of the 16 organizations on our community advisory board at this time, where are they serving across the continuum? What are they providing for their clients and constituents and networks? And then where do we have gaps? So as we try to grow the CAB, we look at that grid to see where the gaps are, and then try to have the community advisors, as well as our other community partners, recommend agencies and advocates who would fill those gaps. And then they go through a vetting process that is ultimately voted on by the community advisory board. So right now I can say one thing that we're missing is we don't really have good representation of LGBTQ communities. We discussed yesterday in our steering committee meeting that we don't have representation from Marin, and I'm saying that now. I think I'm taking an opportunity here because that may be something that we can talk about with representation from Zero. And we have representation now from rural counties as far north as Mendocino, Humboldt County, and Lake County. But what we don't have is sort of a rural committee. So in creating a committee like that, that's local folks who live in those rural areas that effectively we would structurally support to convene, to get a handle on what the cancer burden is in the area, and then to start to develop projects to address it, but also to bring to them investigators within our own faculty who are working on issues in either access or outcomes for rural cancer patients.
One of the questions that came in the Q&A box is, are there opportunities to get involved with any of the initiatives that have been shared here? And can the panelists speak to which ones and how best to do so? And I imagine that there are many more. I mean, that was the purpose of this slide, was to show that there are different organizations and different ways to get in contact.
Can I'm good, I'm open. I was looking, having been familiar with the wisdom study for some time now, I think that one of the ways advocates from various communities can get engaged is see how they can bridge between their community and that study. The problem for some women is whether or not they have access even to broadband or Wi-Fi, understand how to get online, confused by some of the questions. So maybe you navigate them through that online system in order for them to be able to get on board, qualify, and participate. But initially, it was the questions I was asking of Laura Esserman, what about Spanish language? And, what about them understanding? And could we use our community health workers to help you, get these women on? And the study itself has shifted over time and who and how it engages. And that's been good for a lot of communities who were otherwise finding it more difficult to access the opportunity to participate. So it takes both sides to make something that works for both sides, right? That works both for the community you serve, as well as for the institution trying to have a successful outcome in its clinical trials, or any trial, or any research study for that matter.
I'd like to go back to something that Kim mentioned earlier as well, and that is that there are these community advisory groups and patient family advisory councils at a lot of local healthcare facilities, cancer centers. And that is a really good way for people to start making connections and to make sure that the concerns of their communities are being heard. Kim, do you want to take the next question?
I think there was a question in the Q&A about what is the funding to find and support organizations for the new rural groups. I think that's the question. And the Cancer Center is required by the National Cancer Institute to have a community engagement arm. So every NCI center that you might be aware of, Stanford is one, 5 of the UCs are others. I know this is a national conversation. So wherever you see NCI designated comprehensive cancer center, they are required to have a community engagement program. So should inquire in that way. Our office is funded by funds that come through philanthropic donations, as well as grants, and then the taxes that our cancer center director is able to scoop from other people's grant monies. And those funds are put together into a budget that I oversee for supporting each of the different committees that we run. We have a Faith Communities Committee that has about 30 to 60 churches across the Bay Area represented. We've got the San Francisco Women's Cancer Network, which engages with the local organizations that help low-income women get screening mammography, as well as pap smear. And then we've also got the Men's Health Committee, which is sort of focused on prostate cancer at the moment, but I think is about to expand to look at other cancers. The Rural Committee, because of what's going on in Mendocino, Humboldt, and Lake County, will likely focus on monolingual Spanish-speaking clients that they see and navigate who are dealing with hematologic malignancies like leukemia and lymphoma. They also deal with a high American Indian population that lives up in Northern California, but that's all funded through the Cancer Center.
And that's a really good point. There are new resources, and also a lot community-based organizations sometimes can help to coordinate, if not to fund, but there may be volunteer assistance available to help with the rural groups. We do work with the Cancer Resource Centers of Mendocino, and we've also started connecting with the Cancer Resource Center of the Desert down in Imperial County, both very rural areas, and also with the Indian Health Board. Again, this is all in California. So there is in the Q&A information about a person who's been doing work in Florida, which sounds amazing. And I know we're running out of time, so I don't think we can get to any more questions, but I will happily answer those offline. So
and I did offer to the person in Florida. So I'm officially actually an investigator on the Wisdom Study, largely to manage the community engagement piece. And so the expansion of the Wisdom Study has a site, I believe, Jasmine, correct me if I'm wrong, but I believe there's a site in Miami, and I know that may not be near the person who wrote in, but that's where we will probably try to plug that group in, because that would be a big benefit, I think, to the Wisdom Study to have an ongoing engaged activity that seamlessly, could merge with participation in the study.
Great. Well, I want to thank our panelists so much. Oh, we're out of time. I'm sorry, Isabel, but we will definitely, we can put more comments in that will be included online. I want to thank everybody for being here today, our panelists, our co-sponsors, and please stay tuned for our upcoming speakers in July, April, July, and October, as we continue to work on health equity in advancing health equity in breast cancer. Thank you.
Thank you.